Welcome to everybody. I am Paolo Pelosi, head of the Anesthesia and Critical Care Unit at San Martino Policlinico Hospital in Genoa, Italy. Today we will talk a bit about protective ventilation in obese patients. Watch the PEEP. No conflict of interest to declare in this specific lecture. The patient with obesity, and particularly patients in class 3 with a BMI higher than 40 kg per square meter, are at higher risk to develop postoperative pulmonary complication. Lower risk is in patients in class 1 and class 2. Patients in class 3 have the risk of 6% to develop respiratory failure postoperatively and the risk of 2.4% to need mechanical ventilation. In class 2 and class 1, a risk of 1.4% and risk 1% to need mechanical ventilation. And of course, in non-obese patients, much lower with a risk of around 1% to develop respiratory failure postoperatively and mechanical ventilation risk of 0.5%. Further, patients who develop a mild to severe PPC have an increased risk to have a longer time in the hospital. What happens in obese patients during anesthesia and paralysis? In normal patients, anesthesia and paralysis is associated with a reduction in lung volume with an amount of non-aerated tissue around 3%. In obese patients, the induction of anesthesia is associated with a major decrease in lung volume with an increase in non-aerated tissue of an average 11% and ranging from 5 to 17%. And this is associated with major changes in oxygenation and compliance. Body mass index is associated with the increased risk of the developed atelectasis, mainly in the dependent part of the lung. And this is due to the increased intra-abdominal pressure, which increases the pleural pressure and the transpulmonary pressure, squeezing the alveoli mainly in the dependent part of the lung and promoting airway closure in the middle part of the lung. This is a schematic representation of the regional transpulmonary pressure during mechanical ventilation in obese patients at end inspiration and end inspiration. At end inspiration, at PEEP 0, as you can see here, there is a gradient in pleural pressure and in the aeration, with more perfusion in the collapsed areas. When we have an increase in inspiratory pressure due to the tidal breath, at low tidal volume, there is an increase in transpulmonary pressure, but moderate, and no changes in the area atelectatic. When we apply a recruitment maneuver up to 40 centimeters of water, as you can see here, we have a major increase in transpulmonary pressure, especially in the upper part of the lung, with a squeezing in the capillary vessels, but more importantly, as you can see, in the most dependent part of the lung, with completely recruit, we can reach a transpulmonary pressure up to 38 centimeters of water. So we have to take care about recruitment maneuver, very aggressive in this kind of patients. When we apply PEEP, we have a more homogeneous distribution of transpulmonary pressure from ventral to dorsal lung regions, as well as at end inspiration. When we increase PEEP too much, up to 20 centimeters of water, as you can see here, we have a squeezing of the capillaries with an increase in transpulmonary pressure from non-dependent to the dependent lung region, and even more at end inspiration. We know that the end expiratory transpulmonary pressure is a function of body mass index, and it becomes more negative, so there is a higher pressure in the pleura compared to the alveoli at higher body mass index. And we know that we need at least 20 centimeters of water in obese patient in supine position to reach a transpulmonary pressure positive from 2 to 4 centimeters of water in order to avoid opening and closing of the alveoli, and mainly in the dependent part of the lung. So we developed a few years ago the concept of protective ventilation in obese and non-obese patients during anesthesia, associating low tidal volume, minimizing hyperinflation, and a certain level of PEEP to minimize opening and closing lung. So the question here is to maintain the lung more closed or more open by application of different level of PEEP. We found also that in obese patients, the association of recruitment maneuver and PEEP was the only maneuver able, as you can see here, to keep the lung open at 5 and 20 minutes, as compared to low level of PEEP at the upper panel of the figure, or recruitment maneuver associated with lower level of PEEP. So how to set PEEP in obese patients? This is a representation of the changes in driving pressure from end expiration to end inspiration at lower level of PEEP. When we increase the PEEP, we may observe a reduction in driving pressure and a reduction in the stress index due to the reopening of the lung at end expiration. But when we increase too much PEEP and we overdistend the upper part of the lung, we can observe again a further increase in driving pressure. So the increase in driving pressure may be an indicator of excessively low level of PEEP and collapse of the lung, or excessive overinflation of the lung. So we did a study with our colleagues in São Paulo, looking at the best PEEP according to the electric impedance tomography. And as you can see here, we found that there is a specific individualized PEEP in order to balance the collapse and overdistension. And this level, according to the IT, was associated with the best compliance and the lower driving pressure. The PEEP according to the IT, so also the lower driving pressure, was associated with the BMI. Higher was the level of PEEP to keep the lung open and reaching a lower driving pressure, higher was the BMI. Conversely, the reduction in driving pressure, so the improvement in compliance, was more effective at patients with higher BMI as compared to patients with lower BMI. Overall, we observed a minimal reduction in the atelectasis, both after open surgery or laparoscopic surgery, in the group in which PEEP was guided by AT as compared to lower PEEP level at 4. But this reduction was very minimal in open surgery and a little bit higher, but very minimal again, no more than 3 to 4% after laparoscopic surgery. Which is the mechanical ventilation in the real life in obese patients? What we found that obese patients are usually overventilated, reaching a tidal volume even higher than 10 milliliters per kilogram, especially in more obese patients. And volume control is used in more than 70% of the patients. PEEP levels are relatively low, at least during anesthesia in obese patients, and recruitment is used very rarely, around in 6% of the patients, independently from the level of obesity. We also observed that desaturation was common, but not so frequent as we expected in obese patients, even treated with lower level of PEEP, around 15% in class 3, and the reaction of anesthesiology was mainly to apply recruitment maneuver and not increase FiO2. On the contrary, the frequency of hypotension was much more frequent, between 25 to 30%, and the reaction was mainly by using vasoactive drugs and much less using fluids. We also found that recruitment maneuver, especially when performed by back squeezing, were associated with an increased risk of postoperative pulmonary complication, especially in obese patients. We performed a large randomized control trial, the Probiotrial, in which we compared in patients undergoing elective surgery for more than 2 hours with BMI higher than 35 and higher risk to develop PPC, ventilated with low tidal volume at 7 milliliters per kilogram predicted body weight, the effect of low PEEP at 4 centimeters of water or high PEEP at 12 centimeters of water plus recruitment maneuver on PPC at 5 days. Our final results were that independently from the level of PEEP, we observed the same risk to develop PPC in both groups of patients. So there is absolutely no difference between higher and lower PEEP during surgery and PPC, while the group treated with higher PEEP and recruitment was associated with an increased need of fluids and vasoactive drugs. So a large group of people from Europe and United States decided to join together and to write the protective ventilation guidelines during general anesthesia in non-obese and obese patients, mainly coming from our largest trial from the Probiotrial and Probiotrial. So we suggest to use low tidal volume, low PEEP at 5 centimeters water or less, and no recruitment maneuver plateau pressure less than 17 centimeters of water and less than 22 in obese patients, and a driving pressure less than 13 in non-obese and less than 18 in obese patients. If saturation drops down less than 92%, we suggest to increase first FiO2 up to 90%, and if saturation less than 92% persists, we can progressively increase PEEP according to the driving pressure and use recruitment maneuver as a rescue treatment. Further evaluation will be needed for laparoscopic surgery, duration of longer than 3 hours, and the use of Chandelian boat position. What about mechanical ventilation in RDS obese patients? There are mainly a retrospective analysis. This is a very recent study showing the driving pressure was higher in non-survivors as compared to survivors. And this was mainly in non-obese patients, but in obese patients, driving pressure was not associated with mortality as compared to non-obese patients. Further, there is a retrospective analysis from the Algolide trial in which the authors look at the effects of high PEEP 14 versus 9 centimeters of water, and what they found that in more obese patients there was an association towards a reduction in mortality as compared to non-obese patients without any changes in barotrauma. So this data would suggest that in RDS patients with obesity, higher PEEP level might be helpful, but this is not coming from any randomized control trial. Further, prone position improved gas exchange much better in obese patients as compared to non-obese patients with RDS, and also survival appears to be better in prone position in obese patients as compared to non-obese patients with RDS. So prone position appears to be improved survival and gas exchange more in obese than in non-obese RDS patients. Of course, this maneuver requires careful training in order to perform the maneuver in a safety condition. So, to conclude, how I or we ventilate obese patients, and we suggested the I-START protocol. I intubate, anticipate difficult artery management and difficult mask ventilation, pre-oxygenation FiO2 at 100% and use non-invasive positive pressure ventilation, fluids and vasoactive drug readily available for possible hemodynamic impairment. S, set up initial ventilation with tidal volume 4 to 6 milliliters per kilogram in RDS and 6 to 8 in non-RDS patients, low and moderate PEEP with RDS low PEEP table in RDS, starting with 5 centimeters of water in non-RDS patients, gradually lower FiO2. TET tray ventilation parameter with respiratory rate to keep pH higher than 725 in non-RDS and RDS patients and tolerate mild hypercapnia in RDS. PEEP according to the minimal oxygenation and saturation. No recruitment maneuver as a routine. FiO2 to avoid hyperoxia if saturation prioritizes FiO2 increase over PEEP increase. Assess armor for ventilation with plateau pressure below 27 in RDS and 20 centimeters of water in non-RDS obese patients, according also to the interabdominal pressure. Driving pressure below 17 centimeters of water in RDS and 15 in non-RDS obese patients. Likely maintain mechanical power below 17 to 20 joule per minute. Use rescue maneuver, recruitment maneuver, only as a rescue, stepwise by using a stepwise increase in airway pressure. Prone position may be safe and feasible in obese RDS patients and appears to be associated with better survival, and ECMO to be considered only in selected RDS obese patients.